Good afternoon, guests, and welcome to the Weekly with Dr. Tom. This is your way to stay up to date with everything healthcare related across the country. This week, we'll be joined by Dr. Jordanna Kapeluto, UBC Endocrinologist and Obesity Expert. She will help us understand why weight gain occurs, some of the obstacles to weight loss, and the concept of a calorie in and a calorie out. There will be a Q&A session at the end of the seminar. Submit your questions throughout by using the Q&A button at the bottom of your screen. Dr. Elliott will answer as many as possible live, but all will be answered by case managers in writing. We look forward to your engagement. Now, here's Dr. Tom.
Good afternoon, viewers, and welcome to the 12th edition of the Weekly. Today, we're focusing on diabetes and overweight, and are privileged to have Dr. Jordanna Kapeluto, my UBC colleague and obesity expert, as our guest, to give us the most up-to-date advice and to help answer your questions. What constitutes overweight or obesity? There are, in fact, many definitions. There's body mass index, which is weight in meters divided by height in kilos squared, and 19 to 25 is the desirable range. You can measure your waistline with an old-fashioned tape measure. If it's more than 40 and you're a man, you're overweight. If it's more than 35 and a woman, you're overweight. You can do waist-hip ratio as well. Or perhaps simplest of all, you can look at yourself in the mirror wearing your underwear. The bottom line is that 64% of Canadians are either overweight or obese. Well, what is overweight or obesity the cause of type 2 diabetes? The short answer is no. The cause of diabetes is that the pancreas becomes exhausted, unable to make enough insulin so that sugar rises. The main cause of exhaustion of the pancreas is getting older. So obesity is not the cause of diabetes. At the age of 110, everybody has diabetes because their pancreas has become exhausted. Next slide, please, Luke. We're going back to that one in a second. Okay. Now, there is a strong relationship between obesity and diabetes. Here's a slide that looks at data from 300,000 people from the United Kingdom, and it was published last year. I want you to look at the green line. And I want you to look at the two vertical red lines. This is body mass index. An ideal body mass index is between 20 and 25. And you can see that the incidence of diabetes in the green line is very flat and around 1 or maybe 2% when you get to a BMI of 25. As your BMI goes from 25 to 30, that's the overweight range, the incidence, the prevalence of diabetes goes from 1 or 2% to 5%. And then as you go from 30, a BMI of 30, which is one definition of obesity, up to 40, the incidence or prevalence goes from 5% to 20%. So you can see there's a strong relationship with increasing prevalence of diabetes in a population and rising and increasing obesity. What about the brown line? The brown line is people who have a family history of diabetes. Now, family history is a complex thing. It's a combination of nature, genetics, and nurture, habits and beliefs. But you can see that a family history of diabetes has an even stronger relationship with obesity. So if you have diabetes in your family and you're obese, your risk is much higher. Let's go back to that previous slide. Why is diabetes more common in obesity? I'm kind of making this a bit more simple than it really is. But if you're overweight or obese, you have insulin resistance. Insulin resistance means that your body needs to make more insulin to do the job than if you were leaner. The concept is that because your body has to make more insulin, over the years, the pancreas gets exhausted, and then eventually you get diabetes earlier if you are obese than if you weren't obese. Next slide. Well, what's the weight distribution based on body mass index at BC diabetes? 24% of patients at BC diabetes have a body mass index in the desirable range. 38% are overweight, their BMI is between 25 and 30, and then 38% are above 30. You might ask, let's go back to that slide. You might ask, what does obesity affect blood glucose control at BC Diabetes? I can tell you that it doesn't. We are able to control your sugar using all our tricks and advice and medications and strategies, whether you're lean or whether you're overweight or whether you are obese. Next slide. If you are overweight or obese, we are more likely to use medications that have come into common usage in the last 5 years. The left column is SGLT2 inhibitors. This would be empagliflozin, canagliflozin, or dapagliflozin. So obese or overweight patients, about 38% are on this class. Almost 60% are on the injectable GLP-1 class. That's semaglutide or dulaglutide. And 55% of people who are obese are on both drugs. It's time for me to introduce our guest. Dr. Kapeluto was born in Toronto and raised in Kingston and Montreal, where she tells me her maternal grandparents owned a pickle factory, the pickles from which all of you have sampled one way or another in a Burger King burger or vinegar. She did her medical schooling and then her internal medicine and endocrinology training at UBC. She did advanced training in obesity at Laval and won all sorts of prestigious awards. Then in 2017, returned to Vancouver to be on UBC faculty. Jordanna has an office both at VGH and at Richmond General Hospital, where she's part of the bariatric or weight loss surgery program. I've known Jordanna since her fellowship days in 2015. I can tell you she is very much a rising star, and we are tremendously privileged to have her as our content expert today, particularly as she's going on maternity leave in the summer. The importance of this is not just for her, but, and of course we wish her and her husband Fergus, a UBC rheumatologist, all the very best, but we also need to get her back on the weekly for a second visit to talk about bariatric surgery. Enough of me. Jordanna, welcome to the weekly.
Thank you so much. Okay, I'm gonna start sharing my screen just so I can make sure that Luke, is it up? Can everybody see my screen here or?
Not yet, Dr. Kapeluto.
Okay, perfect. You just let me see. Hold on 1 second here. Perfect. So thank you so much, everybody, for having me. It's kind of funny because all of my friends call me the Pickle Princess, even though I have nothing to do with the pickles anymore, but I'll happily wear that badge. And thank you so much, Dr. Elliott, for the lovely introduction. So I agree with a lot of what you're saying. You know, we do see that there is a relationship between diabetes and as our weight goes up. But that being said, you know, there are many people out there who have diabetes without a higher weight, and there are a lot of people with a higher weight who don't have diabetes or any other of what we call the metabolic complications of having overweight or obesity, like high blood pressure or high cholesterol. And that's why it's so complicated. And similar to diabetes, there's no one answer to why things happen, and there's no one way to manage things, which is why it becomes so difficult for a lot of people to manage their weight and understand why their weight can be high. And so a lot of us were raised with this calorie myth where we were told, well, it's just about calories in, calories out. If we eat less and exercise more, then we'll just simply lose weight or everything will be okay. And I think through a lot of people's personal experiences or seeing family members or friends struggle with it, it's not quite that easy. And sometimes when we hear this message, it can be really discouraging that we're not trying hard enough or that we're not doing the right things. And my goal today was just to break this myth and to explain why it can be so incredibly easy to gain weight in this day and age and so incredibly hard to lose weight. So, right, the way our bodies work, we're kind of like polar bears in the desert. We're adapted for an environment we might not live in anymore. So for example, our body still thinks that we're hunters and gatherers who live in a time where food might be scarce. So whenever we have access to a lot of food, our body's natural response is to try to gain weight and try to preserve that weight so that we have access to energy to do our daily functions. But when we lose weight, and especially if we lose weight really, really quickly, our body thinks we're starving. And so it really dampens down and turns down our metabolism to try to hold on to that weight. The challenge is we live in a time that for most of us, food is readily available. And we live in a time where food just isn't as nutritious as it was in our grandparents' generation. So a lot of our foods are really dense in calories, but they don't have a lot of nutrition. And so where our body hasn't caught up, and we have access to all of these high calorie, less nutritious foods, it creates a perfect storm for us to gain weight. And there's a lot of different reasons why this can happen. And I'm not going to go through a lot of these things in detail, but so many different factors control why we gain weight and how we lose weight. And there's two main parts of the brain. So there's a place called the hypothalamus. Think of this as kind of like our total body thermostat. It's the part of our brain that keeps all of our body functions working normally and keeps us alive. And what happens is that every time we gain weight, our body thinks that that's the new normal for us. So when we lose weight, our body is trying to always get us back up to that higher weight that we had. And this is what prevents us from starving, and this is what prevents us from dying. So in a way, in a time when we didn't have access to food, this was crucial to keeping us alive. There's also another area called our mesolimbic system, and that's kind of like our desire zone. So that's the part of our brain that encourages us to eat things that taste good, that allow us to react to emotions with food, the part that makes us remember that McDonald's jingle or a commercial that we saw and all of a sudden crave food. And the best way to explain this, how this part of the brain works, is if, let's say, you were to go to the movies with a group of friends, but you had already had dinner. The minute you step in that theater, all of a sudden your brain is thinking popcorn. And you might not have been hungry, and if you had been at home, you might not even want anything to eat. But the moment you're in that environment, you smell, you remember what it was like and how good popcorn tastes, all of a sudden we all somehow find room in our second stomach and we're going and getting that bag of popcorn. And that's our mesolimbic system. Hormones in our body help us gain weight. And so insulin is one of those crucial hormones that helps us control our blood sugars, but it also promotes us to gain weight. We also have a hormone that's released by our fat cells called leptin, and that's a signal that's supposed to tell us when we have enough fat storage. But as we gain weight, we make more and more and more leptin, and our body gets overwhelmed by the signal and just stops ignoring it. And so that can also lead to further weight gain. We also have our hunger hormone called ghrelin. And what that's supposed to do is signal us when we're hungry is that hormone that gives us those hunger pains and tells us it's time to eat. But again, sometimes this hormone can be released in inappropriate ways and tell us we're hungry when we're not actually hungry, or make us have cravings and make us eat when really we don't need to be eating. We also have what we call peptides, or little proteins that are released in our gut. And these are supposed to be the hormones that shut off our hunger desire, but sometimes they don't work and our body doesn't get that signal. So it becomes almost like a broken telephone, and it can make us eat more than we actually need to, or we just don't get that satisfaction and that cue that we've had enough to eat. And unfortunately, insulin is one of those things that makes us gain weight, which is why as patients with diabetes, especially if we're on insulin, sometimes we can gain more weight when we're put on insulin. It doesn't mean insulin isn't important and it is not needed for our diabetes, but it can make things challenging. And what happens is in our body, I know a lot of people might look at this diagram and think, this looks like the flatten the curve diagram, and you're exactly right. But what happens is the types of foods we eat, they sort of tell our body how to react and how to handle sugar. So the example here is at the bottom, that lighter blue curve, that would be an example like an apple, and that darker blue curve is apple juice. And basically what happens is our body has a threshold for how much sugar it can handle at any given time. So if we eat something like an apple that our body has to digest, it has to break down the fiber, and it has to slowly release that sugar, that gives us enough time for most of us to keep our sugar levels below that threshold so our body can use it as energy. If we have something like apple juice, which is already processed and it's pure sugar going straight into our body, our blood sugar tends to spike really quickly, and our body can't handle that amount of sugar all at once. So either we take insulin, or if our body makes its own insulin, what happens is that extra sugar has to go somewhere, and it gets shunted into our fat cells and makes us gain weight. We also now know that the bacteria that live in our gut can influence how we use energy from our food. So some of us are really efficient energy harvesters, meaning if we look at a bag of chips, we gain weight immediately. But there are other people who have different bacteria in their guts, and they don't harvest energy really efficiently. So those are the types of people who can eat 4 bags of chips and somehow never seem to gain weight. And we know this because when we took mice that had no bacteria in their gut, and then we took stool samples, so samples of feces, and transplanted them into the mice, the ones that received feces from thinner individuals didn't gain much weight compared to the ones who got feces from patients with overweight or obesity, who gained weight really easily despite being on the exact same diet. So we don't have ways to really treat this yet, but this is going to be a really interesting area of the future that's going to help us understand and treat patients. We also know that our genetics, what we inherit from our family, and the environment that we grow up in can influence our weight. So we inherit where we gain our weight and how much muscle we gain. And the best example is that if we look across different populations, like if we look at somebody from Southeast Asia versus somebody, let's say, from Japan, our body shapes, where we gain weight, and our muscle distribution is really different. It doesn't mean our genes have to be our destiny and we're destined to gain weight, but it does make it harder and make it to lose weight for certain populations and easier to gain weight for other populations. We also know the environment we grew up in, it teaches us our eating habits. So we tend to eat the same way our parents ate. The amount of physical activity or the importance we place on sports comes from how we grew up, and how we behave around food also is learned, as Dr. Elliott was mentioning, nature versus nurture. We also know that things in our food environment influences how we gain weight. So a lot of us have traditions that surround food. In my family, if my grandmother's not stuffing my face, it means she doesn't love me. But a lot of us also use food around holidays as a way to celebrate. So that's our relationship to food in our culture and our belief system. We also know that food that is less healthy for us tends to be cheaper. So sometimes a lot of people suffer from food insecurity or limited incomes, and our food choices are based on how much money we have and our monthly budget. We also know now that there's really that fast food, that processed food is cheap and it's readily available. If we had the choice of shopping at Whole Foods, which is incredibly expensive, versus shopping at a cheaper place to get food, we might see differences in terms of the food quality that we have access to. And then for a lot of us, food is a way for us to cope with our emotions. So if we're celebrating, we sometimes eat. If we're comforting ourselves, we sometimes eat. Or if just something is missing from our lives, sometimes we use food to make up for that. So some medications that we have to use to treat medical conditions, unfortunately, also contribute to weight gain. So certain anti-anxiety and antidepressant medications can lead to more weight gain. For those who have diabetic neuropathy and pain that needs to be managed, a lot of the medications we use for that can lead to more hunger and weight gain. Now, Dr. Elliott talked about, we try to use SGLT2 inhibitors or GLP-1 agonists, those injectable medications, for our patients who have overweight or obesity. But for other patients where cost is a factor, we might put them on glyburide or dimicron, and those can lead to weight gain. For those who need steroids for other medical conditions, that can lead to weight gain. Birth control pills we don't use. There's an injectable one that we used to use that led to a lot of weight gain, and certain blood pressure or even anti-allergy medications can lead to weight gain. It doesn't mean that these aren't important medications, but you can understand that as we accumulate a lot of these medications over time, they can help us gain weight. So the calorie myth, it's not as simple as calories in, calories out. Sure, if we eat a lot of high calorie foods, we'll tend to gain weight, but then we have our brain that's controlling it, certain chemicals in our body that can be disrupted, bacteria, our genetics, our relationship with food, and even certain medications that can all interfere with this process. So instead of being a straight calories in, calories out, it tends to be a much more tortuous and difficult pathway for a lot of us to manage our weight. So then, not to be depressing, it doesn't mean that all is hopeless, but how do we actually go about managing this? So it comes with an approach that needs a lot of different moving parts. So where it starts off is with your healthcare provider, whether or not that's a specialist like an endocrinologist or an obesity specialist or even a family doctor. Even just starting the conversation and identifying that it's something you have concerns about is a good first step. We need to work on the mental aspect of things and looking at our food behaviors and our thoughts around food, looking at the types of foods we're eating, because certain foods will be more weight promoting than others. Certain medications, both looking at, are there ways we can reduce the medications that promote weight gain or use medications that help us lose weight in certain circumstances, looking at our activity levels, and where we can improve those. And then in certain cases, for some people, because weight gain is such a hormonal or such a physiological process, sometimes the best method for weight loss and long-term weight loss is having bariatric surgery. And a lot of the population thinks that having your stomach stapled or having a bariatric surgery is the easy way out, and it's not that at all. We're just replacing one issue with another that takes a lot of hard work. So if anybody has ever told you that having surgery is the easy way out, then they've never met anybody who's had bariatric surgery. And so I want to bust that myth a little bit too. And I'm happy at a later date or even in the questions to talk a little bit more about these therapies, but I was only given 10 minutes, so I can't go through all of them today. So the big question is, well, what diet works best? And the answer is that no diet works best, but all diets can work too. And it really depends on the human being. The best diet is the one that we can stay on long term and that doesn't cause us other health problems. But diets that make us lose weight really quickly and then we can't do for a long time are going to set us up to regain weight. Because remember what I said, our body is always trying to get us back to that higher weight. So if we do one of those crash diets where we lose 50 pounds in a month, but then we can't keep it going, the minute we return back to our old habits or even change those food habits, we're going to regain that weight. And then sometimes we even overshoot because of the way our body is trying to preserve our weight. So different diets exist, and they all lie on a different spectrum. There are things like the Atkins diet that used to be really popular, or the ketogenic or low carb, high fat diet that tends to focus a little bit more on protein and limiting carbohydrates, and promotes higher fat intake. There are diets that are more in the middle, things like the Zone or South Beach or Mediterranean diet, and ones that sort of trend us more towards a vegetarian diet. What doesn't quite fit in this model are what we call very low calorie diets. So those are things like replacement shakes, like OptiFast, things like the Bernstein diet, where people are prescribed really, really low calorie diets, or something that is more used in sort of like, not in physicians' offices, but certain clinics, something called the HCG diet. And what these diets have in common is that they're basically really low calorie and we're starving the body. So it does allow for really rapid weight loss, but a lot of patients find they struggle afterwards because they just regain the weight and then some after. And then there's a big question about intermittent fasting. So intermittent fasting falls under a category where what we call time restricted eating, where we're limiting the amount of time that we're using calories or getting calories. And why this can sometimes work for people is because overall, if we're restricting the amount of time that we're eating less calories. So when they looked at studies about how long should we fast for or what works best, what tended to work was somebody who overall took in less calories. If we use that time to eat all of the calories we would normally eat or more, then this type of fasting diet doesn't work as well for weight. But we do know that there are certain foods that definitely make us gain weight, and these are the wrong things to eat. So there was a study, and I'll walk you through this slide here a little bit, but there was a study that looked at, well, what happens if we gave people access to what we call ultra-processed foods. So these are foods that come from fast food restaurants, things that live in the middle aisle of the grocery store that don't look like the ingredient they started from, versus an unprocessed diet, meaning foods that looked like they came from the source that they were originally taken from. And when they didn't restrict anybody in terms of how much they could eat, they found people who were on an ultra-processed diet tended to take in 500 more calories a day than those who had a whole food diet. And the best way that I can explain this is that a lot of these processed foods, they trick our brain a little bit. So usually what happens is when we eat something, our mouth and our brain, or our stomach and our brain, communicate to say, I'm done, I'm full. But ultra-processed foods don't give us that same signal. And that's the reason I could sit down with a bag of carrots, and after a while, I would get sick of those carrots and stop eating them. But if you put a bag of chips in front of me, I could probably eat the whole bag, never feeling full or satisfied. So it tends to trick our brain into eating more. And what they noticed in this study is that those people who were on the ultra-processed diet gained weight, and those who were on an unprocessed diet tended to lose weight. And it's even more tricky than that, because even if we look at how our fast food and our processed food has changed over the years, the New York Times did a really good comparison, and they looked at what fast food looked like in the 80s compared to what it looked like in 2016. And across the board for all different food types, not only did portion size in some areas increase, but even where portion sizes didn't increase, there seemed to be additives to them that meant the calorie count increased a lot. So even though it looks like that burger hasn't changed in size, somewhere within that food, we're getting more and more calories. And when we're not getting satisfied and our mouth and our stomach is not giving us that turn off signal, we're eating more and more of these ultra processed foods. So that's one of the traps that we can get into as well, and why if you've ever met with a healthcare professional who has advised you to focus on whole foods or to avoid fast foods, this is where this data is coming from. So this was a really, really quick overview. You know, I could probably talk for hours if you let me on all of these topics, but just with that brief overview, I just wanted to see if there were any questions I could answer and help people better understand.
Thanks, Dr. Kapeluto. Very interesting subject. So much fascinating information. We are going to go to the audience now and ask a couple questions.
Sure.
The first one is from Meredith. She says, I struggle with weight loss and have for at least 25 out of the last 39 years since I was diagnosed with diabetes. Since insulin is a hormone, how can type 1s who may be taking 10 shots of insulin a day increase their metabolism rate while requiring insulin?
Well, you know, unfortunately, there's no magical way for us to increase our metabolism rate, but there are things that we can do to help boost our metabolism. So any pill out there or any meal plan that claims to boost metabolism probably isn't going to give you the effect that you want. But what we do know is what helps our metabolism is our muscle. So the more muscle we have, the more our metabolism works. So even doing things like strength training, trying to build up that resistance training, building up our muscle can help our metabolism much more. Now with type 1 diabetes, it's tricky because with type 1 diabetes, we absolutely need insulin, and it's something we need to survive. But sometimes working with your healthcare professional to find ways that you can safely reduce the amount of insulin you're taking by looking at what types of foods you're eating, what times of the day you're eating, and how we have those blood sugar spikes, like I showed in that one slide, can often help patients with type 1 get their insulin requirements down, and that can help with weight in some patients.
Okay, the next question is from Donald. He asks, what is the relationship of stress to weight loss or weight gain?
So that's a really interesting question. So stress can influence weight gain in many, many different ways. So one of the ways stress can influence is through our eating habits. So when we're stressed, some of us tend to gravitate towards foods that give us immediate comfort. And for a lot of those are foods that are high in sugar, high in salt, and high in carbohydrates. So for some people, a stress response is to eat less, but for many of us, a stress response is to eat more. So that can make us gain weight. We also know that there's a hormone called cortisol in our body, which influences weight gain. Now, cortisol, if we measure it in a blood test and we're under a lot of stress, we won't see a rise, but we know that those cortisol levels are higher at the level of our fat cells. And so when we're under stress, those cortisol levels at the level of our fat cells are promoting us to take on more fat, more energy and more sugar into those fat cells, and can make us gain weight. And in certain conditions where our cortisol levels are really high, can lead us to gain weight, especially around the middle section.
Okay, the next question is from Samuel, and it's to Dr. Elliott. If semaglutide was covered by pharmacare, would everybody with overweight or obesity be on it?
That's a very good question. There's no doubt about it that it does suppress the appetite and cause weight loss in most people. Somewhere around 10 or 15% of people can't take it. It makes them sick to their stomach, nausea, vomiting, and diarrhea. If I think we would try it on every person with overweight or obesity. Jordanna, what are your thoughts about that?
Yeah, I think so too. And I think the biggest limiting factor for using this medication is cost and side effects. And I think that's a really important question, because I think a lot of us still think of weight gain and overweight and obesity as our fault. We're just not trying hard enough. But we need to start thinking about this as a medical condition the same way we think about other medical conditions. So no one would say to a patient who has high blood pressure or who has asthma, well, why don't you just try harder to get your blood pressure down? Or why don't you just try harder to breathe normally? We would automatically offer patients those medications. And so because overweight and obesity is also a hormonal process and a body process that a lot of us have dysregulation or abnormal body function leading to it, I think we should be open to the idea of using medications in this patient population as much as we need to, if it makes sense for them.
Fascinating. Now, at this point, I'd like to introduce Dr. Mira Zheng, a Chinese-trained cardiologist who has been with BC Diabetes since 2011. A diabetic herself, she is beloved by patients and colleagues alike and is highly regarded for her depth of knowledge and ability to deliver results for the patients she sees. Mira.
Thank you, Tristan. Hi, everyone. My name is Mira, and I'm one of the diabetes case managers and the physician assistant here at BC Diabetes. I joined Dr. Elliott and his team back in 2011. Prior to that, I've worked as a cardiologist in one of the largest hospitals in China for 10 years. And I did my postdoc training in cardiovascular physiology in the States. I immigrated to Canada about 20 years ago, and my family has been living in this beautiful city in the past 15 years. Oh, by the way, I have 2 teenage boys, and one's going to start university in September. So in the previous 2 sessions, Dr. Sidhu and Jerry have provided their wisdom to you. And as a diabetic myself, at this trying time, I just want to mention something which I feel helpful and I want to share with you, is to try to have a healthy coping strategy. That means think positive. Think about the people and activities in life that make it enjoyable. Good stuff will help you get through the tough times. Be good to yourself. Do the best you can. Look at what worked and what didn't, and then move on. Do something that you enjoy every day. And seek support. Join diabetes education classes like the one we're doing every day or every week, the weekly webinar. And the diabetes support groups can help you manage your diabetes and better cope with your feelings. Remember, you're not alone there. Thank you, Tristan. Back to you.
Thank you, Mira. Much appreciated. We're going to have a couple more questions here. Dr. Kapeluto from Mary. Is it true that chemicals and preservatives in our food attach to sugar or carbs and stay in our body longer, contributing to our diabetes? And is there a benefit to eating organic, natural, and non-GMO foods?
You know, I'm not aware of a link that directly says that these chemicals linked to sugar and keep them longer in our body. And I don't know if Dr. Tom knows of something different than that. He might. But you know, the main idea behind organic foods are exposures to pesticides and other things. And there's a huge evolving area of endocrinology research right now looking at what we call endocrine disruptors. So that's a pretty still new area of research, but my understanding is that certainly some of the chemicals we're being exposed to, whether or not it's through food or in certain plastics, we think might disrupt certain hormones in our body. You know, what I could say is that some people believe that organic foods might be more nutritious, they might have more vitamins. Again, I don't know of any data that substantiates that or that promotes it, but Tom, if you know something different than what I know, I'm happy to hear from you.
No, nothing more to add on that one, Jordanna.
Okay.
The next question is from Miguel, and it's to Dr. Elliott. I see many in the media saying that obese is a normal body type. Is that true?
Hello, Miguel. Miguel is a long-distance cyclist who burns an awful lot of calories that way. You know, I think Jordanna, when she talked about the polar bear, you know, there's so much of it around. If you buy it at Costco, it's relatively cheap. And the way we've evolved, yes, we are an obese society. So is it normal? That's a philosophical question. It's common. And you know, Jordanna has touched on just how complex the whole situation is. So I don't think there's a simple answer.
Okay. The next question is for Dr. Kapeluto. What is the explanation for late onset obesity in women, i.e. obesity that occurs after age 60? And that's from Margaret.
Hi, Margaret. That's a really good question. So there's no one simple answer as to why certain people gain weight later in life. Like, it could be through all of those factors that we spoke about. One of the really common things, though, is after menopause, our hormones shift. So we all have what we consider female hormones in our body, like estrogen and progesterone, and we all have testosterone in our body, whether we're male or female, but we have them in different amounts. And what often happens as we age, as we go through menopause, those numbers shift. So a lot of women in their 50s, 60s after menopause find that it's much easier to gain weight, especially in sort of the stomach distribution versus like the thighs and the butt area, because of those shifts in amounts of testosterone and estrogen in our body. The other thing too is, you know, similar to what Dr. Elliott was saying about our pancreas becoming fatigued, as we age, our metabolism just naturally slows down. So in the age of 50 and 60, we get into this perfect storm where we have hormonal shifts, where our metabolism slows down. And unfortunately, our body just cannot process foods, certain food types, and cannot process calories as easily as we could when we were teenagers and we were growing rapidly and we were needing a lot more energy for all of our body processes. So not everybody, when they reach that age, gains weight into the overweight or obesity range, but a lot of us find it's much easier to gain weight as we age and much harder to lose weight for some of those reasons.
Okay, thank you. One more question before our next break. It's from George for Dr. Elliott. I work a very physical day job, so I'm generally fit, but I have had a hard time with my waistline. I only seem to be gaining belly fat, and I can't seem to slim down. What do you recommend?
Well, George, you're not alone. I don't have a physically demanding job, but I'm gaining belly fat, and it's a constant struggle. It isn't just as simple as eat less and exercise more, but that is my short advice to you. Jordanna, I know you spent your whole lecture on this, but do you have anything further for George?
Same idea, just as we age, we don't metabolize as well. And so, and it gets frustrating. So there's this common idea that, well, if I take in 100 calories, but then do 100 calories worth of exercise on my bike or on my treadmill, then it's going to even out. And it unfortunately doesn't work that way. Even if we have a physical job, when we're trying to lose weight, our physical job or our day-to-day, that's where we're starting from. If we're trying to lose weight through exercise, we have to add something on even more. And so that's why, again, it becomes really difficult to lose weight, especially if we're busy and we're tired at the end of the day.
Thank you, Dr. Jordanna. Now we are going to go to Arthur's Corner for his third edition. Dr. Weisinger, who's our staff scientist, will be discussing blood sugar and blueberries. Arthur.
Thank you, Tristan. Science is fascinating indeed. And today I'd like to talk to you for just a moment about blueberries and type 2 diabetes. Could I have the first slide, please? This recently published study looked at the effects of eating blueberries by overweight men with type 2 diabetes. Notice that this is a placebo-controlled, double-blind, randomized study. This is the gold standard. Blueberries contain some interesting compounds called anthocyanins and phenolics that are known to affect digestion. Slide, please. During this study, the treatment group ate 22 grams per day of freeze-dried blueberries for 8 weeks. The control group ate 22 grams per day of a placebo powder made of sugars and flavorings and colorings to resemble the blueberries. Slide, please. Consumption of blueberries improved cardiometabolic health parameters in men with type 2 diabetes. It absolutely worked. After 8 weeks, the group who had eaten blueberries had showed a significant reduction in A1C and fructosamine, both biomarkers for glycemic control, and also exhibited significant decrease in triglycerides. Thanks, Luke. This report suggests that eating blueberries can improve blood sugar control and have other positive effects for people living with diabetes. I'd like to point out that this is important to remember that this is only a single study and that it hasn't been repeated. However, the results are interesting, and for once it could lead to a dietary change that's actually pleasant. That's all for today. Thanks very much, Tristan.
Thanks, Arthur. We're going to jump back into the questions. First one is from Mark to Dr. Kapeluto. How can you increase good gut bacteria? Do probiotics work?
So that's a really good question. And so right now we know that the types of bacteria we have in our gut can definitely affect our relationship with food and weight. So far, though, a lot of these studies and a lot of what we know is really limited to rodents like mice and rats. And so because humans are such complex people, because our gut bacteria is influenced by our antibiotic use in the past, the types of foods we're eating, or even the environment we live in. So we know that the bacteria that live in your gut will be similar to the other people in your household. We just haven't been able to identify, well, is there one bacteria or a perfect ratio or a perfect amount that will help us with our digestion or help us with our diabetes. So right now we know there's a difference, but in humans we don't know which bacteria those are. So be careful with probiotics. They can be really helpful for like our gut health, sometimes for bloating, for diarrhea, but we haven't quite identified which ones can really help in terms of diabetes or weight yet. And I think in the next 5 years we might have better answers, but we just don't have those nice controlled studies where everything is perfect in humans yet that we have in mice to be able to answer that question.
Thank you. The next question is from Luke to Dr. Elliott. Can you tell us more about bariatric surgery? Who should go for this kind of surgery, and is it risky?
Well, Luke, the expert is our guest, so I'm going to defer to Jordanna. Jordanna, can you answer that question? And I know we're going to invite you back to talk further about this subject, but in 1 minute, can you answer that question?
Yeah, so we definitely have clear cutoffs. The whole goal of a bariatric surgery. So some people undergo bariatric surgery because it can help with their blood pressure, with things like sleep apnea and diabetes, regardless of weight. But we do have cutoffs because we don't want people to lose too much weight. So we use the body mass index, the BMI, and usually we say if your BMI is above 35 and you have another health issue, or if you're somebody who's otherwise healthy but has a BMI above 40, then you would qualify for bariatric surgery. Now, in terms of risks, the actual surgery itself, if it's done at a reputable center with expertise, is no more dangerous than having your gallbladder removed or your appendix removed. So if it's safe for you to undergo anesthesia, to be put to sleep, to have surgery for one of those procedures, then it's safe for you to have a bariatric surgery. The difference is, though, we're changing the entire anatomy of your gut. And so the challenge with bariatric surgery is patients need a lot of counseling before they go for a surgery and a lot of counseling after to understand how to use their surgery. Bariatric surgery is a tool, and if we don't know how to adapt to it properly or use it properly, then we can have a lot of complications from it, or we might not have the desired effect. And I am more than happy to talk about this another time because I think it's a great question that can benefit a lot of patients.
Now, before we have our last few questions, we're going to go to Dr. Elliott, who's going to tell us about arisehf.
Thanks, Tristan. This is just a reminder to you all that we do still run a number of clinical trials at BC Diabetes. Everything has been shut down during COVID, but it's now beginning to open up. So one of the conditions that can affect people with diabetes is that their heart muscle doesn't contract properly. And I'm not talking about the commonest cause, which is a heart attack. So we will be reaching out to invite you to participate in this study. It'll just require a blood test to start with, and then we'll tell you more about it. Back to you, Tristan.
Dr. Kapeluto from Gerard. For individuals who have lost significant weight and were able to keep it off for more than a year, has their body established a new weight equilibrium? Or are their healthy habits stopping them from driving back upwards?
So very, very good question. So what we do notice is that when people lose weight, ultimately they're going to reach a plateau, meaning they're going to reach a point where their body won't allow them to reduce weight. But what we also know, there was a study that looked, I don't know if anybody ever remembers that show, The Biggest Loser, but what they did is they looked at people who participated in that program. And what they found is those who lost weight really quickly, their body adapted by lowering their metabolism. So if their metabolism was working at 100% before, it can sometimes go as low as 20 or 30% of what it was when they had extra weight. And that's because we need that metabolism. We need that extra calories, like that ability to process calories to keep our body functioning at a higher weight. What happens in those patients is their body finds a new normal, but they're always at risk, like we spoke about, of regaining that weight again. So those who have been successful in losing weight and keeping weight off tend to be those who found some sort of lifestyle routine or diet that they can keep going long term. And depending on how the weight was lost, if it's through medications, medications can help keep that equilibrium, keep that weight loss stable. Or things like bariatric surgery can also adjust our hormones. They adjust the gut bacteria that we were talking about to allow to keep that weight off. We also know that there are certain habits that people who are able to maintain their weight they have that are more successful. And part of that is being active for at least an hour a day and limiting screen time to an hour a day as well. And we also know that those who are successful in keeping their weight off are weighing themselves at least one time a week to get that extra feedback. So I know it's not a direct answer, but a lot of people are able to maintain that weight loss, but some aren't. And so it's a little bit more complicated than just adjustments in our body's metabolism or our body's function. But those who are successful are usually the people who have been able to find habits that they're able to maintain long term.
The next question is from Trevor, and it's to Dr. Elliott. Is vigorous physical exercise recommended if I am on insulin and also intermittent fasting?
That's a good one, Trevor. Well, if you're on insulin and you exercise, there's a good chance your sugar will go down. if you do, the more vigorous the exercise, the more likely it is that your sugar is going to release stress hormones like cortisol that Dr. Kapeluto mentioned. Your sugar actually might rise during the stressful exercise and then come down later. And then, of course, the other factor is intermittent fasting. If you're, if you're fasting, the glucose in your body is coming from your own muscles and your liver. So you better make sure you don't have too much insulin on board. So that's why we want you to have a CGM device. And Minister Dix, if you're out there listening, our efforts to get CGM covered as well as semaglutide will be unrelenting.
Dr. Kapeluto, this next question is from John. He says, I understand that muscle weighs more than fat. So is BMI a realistic measure if you are fit, not overweight, and work out at least 3 times a week?
That's a really, really good question. And the answer is probably not. So no way that we measure our body weight is perfect. You're absolutely right. Muscle weighs more than fat cells, but fat cells take up more space. So if we took the example of The Rock, who is very muscular, I promise you his BMI is probably in the overweight or obese range. But when we look at him, he's not somebody who has a lot of fat cells on his body. And so that's why BMI is one measure, but we would never take that number in isolation. We would look at the whole picture. And so that's why Dr. Elliott was talking about waist circumference or measuring our weight as a way of also knowing where our fat lies and whether or not it's too much. And in experiments and research, we also do things called DEXA scans. So for those of you who have had a bone density test to look for osteoporosis, we can also use that type of imaging to see how much body fat someone is carrying. So it's all of these bits of information that lead us to say whether a BMI is appropriate or not. If you also look at BMI, like I said, different cultures have different natural distributions and body weights. So what we consider a normal BMI in Canada, that's based on a Caucasian or a Northern European population. Those cutoffs don't apply to people who are from certain Asian populations. So a normal BMI in somebody from China or Japan would probably be between 15.5 to 20. Much lower than what we quote. And we also know in patients of Southeast Asian descent, so people from India, Pakistan, Sri Lanka, Fijian, they can start to get metabolic problems like heart disease, diabetes, high blood pressure at a much lower BMI, like 21. So if we only use the BMI, I think we're missing the risk in a lot of our populations, or we're oversimplifying it. So that's why we look, when you come to a doctor's office, we look at you as a human being and as an individual, not just a number.
Okay, thank you. We have time for one last question here. It's from Barb to Dr. Elliott. How does one get considered for bariatric surgery?
Thanks, Barb. Well, you need to be overweight, and I think Jordanna pointed it out. Your BMI, all things being considered, has to be at least 35, and you have to have one other thing going on, sleep apnea or heart disease or something like that. And if you don't have something else, then it's got to be above 40. So that's the starting point. On our website, bcdiabetes.ca/handouts, if you search on bariatric surgery, I've got a handout, and on it I've got the testimonials of two BC Diabetes clients who've been through it. And one of them describes a terrible experience, but says, at the end of the day, it was worth it. That's the one I think you should look at. The other one describes an experience that wasn't that tough, and it was worth it. So I think, I do think it's an important therapy, and I do look forward to getting Jordanna back again to talk about it. I do know that the province only offers 200 a year. So, even if you want it, the waiting list is very long.
Jordanna, we have one more question, popular demand. It's from Lucia. She asks, I have been told by friends that one of the reasons I'm having difficulty getting pregnant is because of my BMI. I have a BMI of 42. Is that true?
So it can be. So there are many women who can get pregnant carrying extra weight, but we do know that as our weight goes up, it can go with certain medical conditions, something called polycystic ovaries, which means that our body doesn't produce eggs as regularly, or our hormones don't allow our uterus to get prepared for a pregnancy as easily. And we also know that as our body weight goes up, women are more likely to have miscarriages or can have more pregnancy complications. So the short answer is yes, women who have extra weight can find it more difficult to get pregnant or keep a pregnancy throughout the whole term. But there's also so many other reasons why it can be really difficult to get pregnant. And so, you know, if you're struggling with that and you're ready to get pregnant, you know, that's why seeing an endocrinologist or a specialist who can look at you as a whole to look over what the reasons are that you might be having difficulty getting pregnant, that would be a really good idea. But I think sometimes in medicine, we put people in categories a little bit too much and we make certain assumptions. So it might be true for you, Lucia, but it might not. And but I don't want you to be self-blaming or think that this is the root of all your problems, because there could be other things going on too.
Okay, at this point, we'd like to go to Dr. Elliott for his outro. Tom.
A big thank you, Jordanna, for your wonderful insights today. It's been a wonderful educational program. I know so much more than I did previously. Just a reminder that next week we will discuss diabetes and foot health with guest podiatrist Dr. Amandeep Randhawa. And on June 25th, we'll be diving deeper into insulin adjustment and carb counting, and we'll introduce a new diabetes staffer, Dr. Peter Ling. We apologize for not being able to answer all questions live. Any unanswered questions we will provide written answers to via email. Goodbye, everybody.
Now, at this point, we'd like to say a special thank you to our partners, an even bigger thank you to Dr. Kapeluto, who is fantastic, and our beloved audience. Have a lovely end of your week and enjoy the weekend. See you next Thursday.